I want to acknowledge the absence in the room, and unfortunately, it's just 1 hour today. Reza is recovering from surgery that he had on Tuesday, and he valiantly presented a case on Patreon yesterday, which was one of the most fascinating cases I have ever heard of. It's a diagnosis that I don't think I could find, even if I tried to find it, but it is real. And if you're all inclined, you should totally, absolutely, Rafa, you should totally check out our Patreon page. You just Google CP Solvers and Patreon. In that case, even if it's just for that case, I highly, highly recommend it. I will tell you that I got nowhere near the correct answer, and humbled by that, which prompted a lot of reflection and reading, which I'm excited to share with you in the near future. I want the case to first come out. So it'll just be me today, alongside the incredible CP Solvers crew we got to hang out with and say hi to and behind the scenes. So I'll open it up for the next 30 seconds to a minute to see if anybody has a case. So if you have a case, please volunteer to present it. In the meantime, Maria, what are you eating? What is it today? Nothing?
It's the same as almost every other day. It's chilaquiles.
Show us though.
No, because it looks awful.
What do you mean it looks awful? It looks very mushy.
It's mushy, but it's so good. It's just basically nachos, but for breakfast.
Right.
But yeah, like I don't know. I miss your Swiss cheese sandwich, Maria. Yeah. I'm sorry if I'm always eating. But yeah, those are my chilaquiles, and I don't know if anyone's here like from Mexico or Latin America, but that's like my go-to breakfast.
Oh, amazing. We talk about food like no other. Daniela was just telling us about her birthday barbecue, and now we're learning about your breakfast. I will admit that the only reason I'm not having my yogurt is because I tried something new today. I have some croissants at home, and I cut it open and put some cookie butter in it. And I've never had cookie butter before on a croissant, and it's unreal. You have to toast your croissant for a little bit in the oven. I recommend that. It comes out really crispy, and some melted cookie butter. Oof, I'm good for the next like 6 hours, I think. So yeah. I also wanted to
Sounds amazing. I really want to eat that now.
You know, cookie butter is hard. Is cookie butter easier to find in Brazil? It's almost impossible to find here in San Francisco. Yeah.
What is cookie butter like?
Oh, I was so afraid that you were going to ask me what cookie butter is. I think cookie butter is a butter.
I've tried one that I think it is cookie butter. Is it like just kind of like peanut butter, but instead of peanut, it's just cookie stuff?
I think so. I don't know. I think we might.
I had one that it's called Biscoff.
Oh, yes, that's actually the brand that I had.
Oh, it's very good. So I think we are talking about the same thing.
I think so. Although I think there's potentially a cookie butter expert in the audience in the form of Lauren, whose discussions on the student VMR I'm a huge fan of. Lauren, are you in a place where you can tell us more about our cookie butter options at Trader Joe's? If not, that's totally okay.
I think there's only one, to be honest. I haven't seen more than one. And I think it's like a cinnamon shortbread kind of taste, I think.
Cinnamony. Okay. Is it just like the Trader Joe's brand cookie butter? Okay.
Yeah.
Okay. Cool. Awesome. Well, thanks for joining us today and for letting me know about that option. I didn't know it. All right. We're Simone is getting very, very, very angry. She accuses me of bullying all the time, and I feel like now the bullying is coming back to me to get a move on. And the good news is we actually do have a case, and it'll probably be her 1000th case on VMR, but Catarina, our dear friend from Portugal, has a case prepared for us. So do you want to unmute yourself, my friend, reintroduce yourself to the crowd, and we'll jump right in.
Hi, everyone. So I'm the European representative from Portugal. I'm an internal medicine resident, and I have a great case for you today. It's not a Q fever, I promise.
Oh no, I don't know if I can listen anymore.
Okay, so we can start. If everyone is ready. So I'm going to do the chief complaint and the HPI together because it's pretty short. And the story is, this is a 70-year-old man with sudden loss of vision in his left eye, with no other presenting symptoms. And this had been going on for a couple hours when he presented to our emergency department. I will pause here.
Sorry,
Ooh.
can you repeat just the chief complaint? I'm very sorry.
Sudden monocular vision loss, left eye.
All right, y'all. So I'm really, Katarina, I'm really glad you're presenting this case because I don't think we talk about this often outside neuro VMR. And I think neuro VMR probably biases us a little bit because we almost know that the answer is neurologic in nature. And the only thing that I can offer is to give you a sense of what it's like to be on the front lines before neurology is even called. And the truth is, this is not an uncommon complaint for folks who work in the emergency room, as I learned you do too. And here's the tension. You don't know that this is sudden, and you don't know that this is monocular. And let me tell you why. Whenever a system like the eyes has so much reserve in it, sudden may represent truly a sudden onset of a phenomenon, or it may represent the sudden loss of reserve. How can you remember this? This is a story that I learned from Aaron that I'll never forget. A pen can drop to the ground straight from the sky if you drop it, or it could have been rolling off a table for hours, days, years before it reaches the cliff and falls. So when this person loses vision suddenly, we have no idea if they went from 200% to 50%, or if they went from 200% to 150 to 100, and then less than 100 suddenly. And that's the key tension. And yes, Simone is telling me to tell you the cataract story, which I promise to share in a moment. But the short version of it involves me having the patient having sudden onset visual loss. But the truth is that he accidentally covered his correct eye and thought that his vision was lost, but in fact, he just had a cataract. So he had a cataract in his left eye, but it was slowly progressive. And one day he was kind of rubbing his right eye. It was like, oh my God, I can't see. But the truth is that his right eye was compensating for a cataract in his left eye. And organs that have a tremendous amount of reserve, like the eyes, your eyes have so much reserve, which is why patients with diabetes don't notice their vision loss. I mean, the number of examples to prove that your vision is redundant is numerous, and it's redundant because it's so necessary. So we don't know this is sudden, and we don't know it's monocular. Even if you are a medical person and all of a sudden you start to not see well on the left side, you have no idea if it's the left eye or the right side of your brain causing a left visual field cut. So differentiating between the left eye and the left visual field cut is virtually impossible for a non-ophthalmologist. If you know medicine and you have a family member or whatnot, you can ask the patient to cover their perceived affected eye and see if their vision goes to normal, but most people don't do that perfectly well. So what do we do in real life? We assume the worst case scenario. We assume it's sudden, and we assume it's neurologic in nature until proven otherwise. But on quick examination, you can make a lot of progress. You won't be able to determine the sudden part on exam, but you can quickly determine if it's monocular or binocular on exam. And that's determined by having the patient cover the eye. And if the visual vision is only lost in one eye, the problem is in the eye or the optic nerve. And if there's visual loss in both eyes, that is either because you have a disease that began simultaneously in both eyes, or more likely you have a lesion in the contralateral brain that explains both visual loss. So to summarize, this could be sudden, probably is, but maybe not. It could be monocular, or it could be a visual field cut masquerading as monocular. And the way to distinguish the latter is to have the patient cover the eye. A visual field cut will present as visual loss in both eyes. A vision loss in one eye will only be present in one eye. All right, Karina, back to you.
Okay, so the HPI, he was readying everything for Christmas dinner, and he was in the kitchen just cooking, and suddenly he described that his left eye felt like there was a curtain falling over his eye. There was no headache, no nausea, no eye pain, no fever, no other complaints other than this sudden vision loss. So he called his son, who is a doctor, and he told him, you need to go to the ED immediately. And so he did. And I'll go into his past medical history. So this man has quite a heavy history of cardiac disease. He has non-obstructive hypertrophic cardiomyopathy that has been followed by a cardiologist for a while, and also mitral valve prolapse with very severe regurgitation. And he was admitted in the cardiology service for a month, and he was discharged just a few days before he presented to our ED. So a very recent hospitalization. Other than this, he also has permanent atrial fibrillation. And he has also a pacemaker for sick sinus syndrome for over 10 years. And his meds, he's on bisoprolol, furosemide, nitroglycerin, spironolactone, and edoxaban. Okay. He has no allergies, no family history that is relevant to the case. He's retired and doesn't drink, doesn't smoke, and never use any intravenous drugs. So should I go into his physical exam, or do you want to pause here and talk about this information a little bit?
I'll just share a quick reflection, which is to tell you that for those of you who well, actually, I just step back and say one of the most common causes of this complaint, monocular vision loss, is a central retinal artery occlusion. So it is an occlusion of the main artery that supplies the macula and the retina. And you may wonder what happened to that probability right away. As soon as we heard that this patient had atrial fibrillation, it went up, because patients with atrial fibrillation have a higher risk of embolic disease to the eye and the brain. And then you may have asked, well, what happened to that risk when as soon as he started on anticoagulation for his atrial fibrillation? And that's where it's really important to know that anticoagulation reduces the risk of thromboembolic events, but does not eliminate it. These are all relative risk reductions. So the patient is less likely to have an embolic event than somebody who has atrial fibrillation not on endoxaban. And I don't know if the risk goes back to normal or if it goes back to higher than normal. So people walk around with the risk of having this period, and that risk is higher in atrial fibrillation. Anticoagulation certainly doesn't reduce that risk beyond somebody who doesn't have atrial fibrillation. So the risk of that diagnosis is still there. And I think the key question now is, what is up with the eye? Is it monocular or binocular? And two key things. First, patients with central retinal artery occlusion have a high rate of a concomitant stroke in the brain. So keeping an eye out for previously unrecognized neurological lesions will be really important. And two, not anchoring on that diagnosis will be very, very important, because the possibility of another vascular event, namely one that involves the posterior ciliary arteries as a result of giant cell arteritis, is going to be important too. So this is somebody who you would probably feel a temporal pulse for, ask to see if they have jaw claudication right in front of you. So while we get much more data, I would say prioritize the eye, look for concomitant neurological disease, and make sure that GCA is on your mind and maybe do some exam maneuvers to try to bring that out. All right, Katerina, back to you.
Okay, so when he came in, his blood pressure was 110/50. His heart rate was 110. His respiratory rate was normal. He was setting at 100% on room air, and his temperature was 38.5 degrees Celsius. Okay, he looked well. He was a little scared that he wasn't seeing anything out of his left eye. And when we went into his neuro exam, it was confirmed that he had complete amaurosis of his left eye. Okay, with no other abnormalities. His cardiovascular exam was normal, so was his abdomen and his pulmonary exam. And we asked for him to be seen by ophthalmology, and what they described was that he had hypopyon of his left eye, and they couldn't do a frontoscopic exam because of severe vitritis. Okay, and I'll go into his labs just to tie everything up. So his white blood cell count was 11.5 with 80% neutrophils. His hemoglobin was 9.7, which was at his baseline after being discharged from cardiology. His platelets were 187. His glucose was 235. His creatinine was 1, and his BUN was 38. His sodium was 131. His potassium was 4. And his C-reactive protein was 180. Okay. I'll pause here.
Holy smokes, y'all. This got we just took a really, really rapid, sharp right turn. So what I'm actually going to try to do is a little bit unusual, which is to have to pause for 30 seconds and have you all collect your thoughts, because there's probably some slow thinking we have to do. So I'm going to mute and get all your thoughts in the chat, please, please, please. Okay. Utter silence. Yeah. Maria, why are you scared?
First, because nobody said anything.
Yeah, I know, right? It's like,
yeah, it's always scary. But then, like, I agree that we were thinking something vascular, and then things like really pulled us into another direction with the fever, the hypopyon, which I learned through Google that is an exudate rich in white blood cells, and high white blood cell counts. So it wasn't what I was thinking was going to happen, and I'm just worried about this person's eye. Have no idea what I would do next.
I think with your reasoning, I'd argue you seem to know what you want to do next, which is that you've recognized this is very, very unusual, and you probably cannot take this case home by yourself. And what you really need to do in real life is lean on the people who are experts in this disease, the ophthalmologists. And I can't tell you the number of times where somebody comes in with eye complaints where you're like, no, I got this. Like their vision is a little bit blurry because they have they actually have blepharitis because their oil is not, like, there's so many internal medicine problems that that are not ophthalmologic in nature. And what you really need to know is that this is not something you need to solve. You definitely need to do it with the help of your ophthalmologist. And the role of practicing this case is to be that much wiser the next time, but should never be able to manage this case on your own. Anita, do you mind unmuting if you can and telling us more about your thought, which I think is spot on?
Yes, I thought he would have severe UVI. Do you hear me?
Yes, hear you very well.
Okay, well, I thought of severe uveitis anterior because that's basically what I think of when you say hypopyon. And also medial, there's anterior, posterior, and
Well, I think we lost you for a second there. But I heard all the threads that you were saying, which is basically you were telling us what uveitis is, which is inflammation of the uvea, and you were telling us that it can be anterior, posterior, or diffuse, which is absolutely spot on. Thank you so much. And I saw Christina also was talking about autoimmune disease. Christina, do you want to tell us more what you're thinking? Yes, you can.
I know that the optic nerve is often associated with multiple sclerosis and some other autoimmune etiologies, but this also is a male, and multiple sclerosis is often female.
Yeah, totally. Yeah, autoimmune diseases are less common in men for sure overall. Yeah, Christina, I think this is the first time I'm meeting you. Can you tell us where you're calling from?
Yeah, I'm an MD PhD student, so my institution is University of Alabama, but I'm currently doing my dissertation at NIH.
Nice. That's
So
awesome.
yeah, I'm trying to keep my clinical knowledge up.
Sure. Now, if you're going to ophthalmology, this case will be very, very helpful. But even if you aren't, I promise we'll learn a lot together. So I really commend you all for knowing that this is different. And I will tell you that my confidence about what I'm about to talk about is limited because this case is very unusual and stretches my knowledge base as well. So what is the problem here? The problem is an inflammatory disease of the eye. And that's all I can confidently say, which is very unusual because most diseases of the eye are bland, non-inflammatory. Now, where can the inflammation arise? As Anita was telling us, it can arise in the uvea, or the anterior uvea. It can arise in the vitreous. It can arise in the retina, or it can arise in the optic nerve. And the names for those conditions are uveitis, anterior posterior, retinitis, or optic neuritis. And all those things have either infectious causes, autoimmune causes, or rarely malignant causes. But what is this? This is probably a little bit different. Why? We see involvement of the uvea with the ophtho-exam, but we also see involvement of the vitreous. And involvement of the uvea and the vitreous is essentially involvement of the humor that connects the two, the fluid that connects the two. So the concern would be that this is endophthalmitis, an inflammation of not the uvea alone or the vitreous alone, but of the fluid that connects the two. Endophthalmitis, unfortunately, is a devastating consequence of ocular surgery and is termed exogenous endophthalmitis, and it's not uncommon. Okay? Endogenous endophthalmitis refers to getting this kind of infection without trauma or without surgery. And endogenous endophthalmitis is very, very concerning for the possibility of a disseminated infection, which maps on to some things we know pretty well, staph and strep, but the higher consideration of two unusual organisms, and that's Candida and Klebsiella. So what do we make of the fact that this patient has been previously well? I think you have to put that into question and dive deeper into how the patient's actually been feeling. And what clue do we have about what's going on beyond the base rate? The base rate will tell you staph and strep, but the base rate is the hyperglycemia. The hyperglycemia here has this worry about what kinds of infections patients with diabetes get. And these are many, Staph aureus, but this very specific infection, hypermucoviscous Klebsiella. Very, we can talk about that if it turns out to be the case, but then also Candida. So what do you need to do in this patient? I'll give the screen back to you all. You need to get blood cultures. You need to sample the eye. You need to look very closely at a UA because Candida tends to come from the urine in these patients. And you need liver enzymes. Why? The most common location for Klebsiella hypermucoviscus strain is actually a hepatic abscess. And so you might need liver enzymes and or imaging of the liver itself. What am I most worried about? I'm most worried about endocarditis, given this person has a pacemaker causing endophthalmitis from staph and strep. But I'm also worried, given their diabetic state, about Klebsiella. Why am I worried about Klebsiella? It's so morbid and devastating and lethal. So I'll pass the mic back to Katerina, but I would emphasize inflammatory eye disease, uvea, retina, optic nerve, or the fluid that bathes the eye, the vitreous/aqueous humor, and that's called endophthalmitis. Endophthalmitis can be exogenous, much more common, versus endogenous, which is much less common. All right, Katerina, back to you.
Okay, so that was pretty great, Rabbi. You really hit the nail on the head. So the ophthalmology actually saw this patient first, and they came to me talking about the patient because they were really worried about this being endogenous endophthalmitis. Okay, and he was okay. So we waited a little bit to see what would happen. And they went into the OR and they sampled fluid from the eye. We sampled his blood. And I went through what had happened in his previous hospitalization in cardiology. And I saw that the last week of his hospitalization, he'd been febrile. Okay. So maybe something was really happening before this, as Maria said. Okay, so yeah, we, because they were really worried about this being endogenous, so really not a primary problem of the eye, but the eye was a concern because the problem with endogenous endophthalmitis is that you are at risk of losing your vision or even your eye forever. So this needed to be treated really quickly. And the surprise was that his blood cultures and his vitreous humor grew MSSA. And at this point, we did a TTE that showed no evidence of vegetations. Yeah, he had no trauma to the eye, no eye surgery, nothing. Okay, and he was diagnosed with new onset diabetes through his A1C. Yeah.
Yeah, I think MSSA, Staph aureus, is one of the most common causes of endogenous endophthalmitis, and it's not uncommon that we don't know where it came from. Most importantly, kudos to you for actually realizing that the syndrome begins well before the patient thinks it begins with his fever and the hospitalization. And I think I'm starting to notice that that's a theme of your cases is a shrewd analysis of the past before it unfolds before you. And I think the question here is the TTE sufficient to exclude endocarditis? And I would say the answer here is probably not. The endocarditis here can be a valve-related endocarditis. You can actually analyze that better. You can see what's called the impedance of the pacemaker. So the pacemaker that he has, you can study how much work the pacemaker needs to exert to function. And so electrophysiology can tell you, hey, all of a sudden the pacemaker needs more volts to activate the heart, and or you can get a TEE. Sometimes, given the pretest probability, you just empirically take the pacemaker out. So I'm curious what you all thought about that question and how that evolved.
Okay. Yeah, so we were pretty worried about that for that exact same reason. So we did a TTE and then a TEE, okay? And that showed no vegetations anywhere, including in his pacemaker catheter, okay? And it was, they saw it really well and they say, there's nothing here. Okay, so Then we treated him with the flucloxacillin, and he was doing well. His epopion was receding. He was regaining vision, but his blood cultures kept coming back positive for MSSA. For 2 weeks, still positive. And things were resolving. He had no vegetations, so we had no idea what was happening. So we did a CAT scan of his whole body. His cerebral scan was completely clear because I'd had a previous bad experience, as you've heard, also on VMR, but he had multiple cavitated lesions on his lung. They were small, but there were a lot of them and they were dispersed. Yeah, so we ended up diagnosing him with metastatic MSSA infection with endophthalmitis and lung abscesses with no endocarditis.
Oh man. Whoosh, that's, and you know, that twist is, well, this whole case is crazy in many, many ways. I think as Anne-Marie is saying, where did it come from and where did it go? And often we don't know where staph came from, but we know where it goes. And it goes usually to the heart and spine, but can go almost everywhere. I think it's crazy to think that somebody had that many metastatic foci of staph in his lungs with a normal respiratory rate, no dyspnea, and normal O2 sat. Absolutely bonkers. But it goes to show you, when somebody has persistent bacteremia, you need to go on the hunt for the source. And the source will often be the heart or the spine, but can be anywhere, really, anywhere. I've seen a buttock abscess be the source of persistent bacteremia. I think Kushal's point about that usually the lung infection doesn't need to be drained and usually is cleared with antibiotics. But that's very, very humbling. I'm curious, Katerina, what ended up happening? How did you manage him and how did he do? Oh, you're still muted.
Sorry. He was actually discharged on home hospitalization because he was doing really well, and he continued his antibiotic. He ended up repeating his echocardiogram later that still showed no vegetations. But we were really worried that because of the persistent bacteremia, it could still invade his valves, because he had severe disease of his mitral valve, and his pacemaker. So we ended up treating him as if this was endocarditis, even though we had no evidence of that. It was a big risk, so we did it. So where did the MSSA come from? Probably the skin. He was hospitalized for a very long time. He was an undiagnosed diabetic, so no control over there. And he had a lot of catheters put in. So yeah, the skin was probably the origin during the hospitalization, and then it spread everywhere. So yeah, it was a pretty cool presentation for MSSA that I'd never seen before with endophthalmitis. So yeah, that's why I brought the case.
You know, we often say that the eyes are a window into the soul, and that's very, very true if you're a poet. And they're also, unfortunately, a window into devastating disease. And sometimes that devastating disease is giant cell arteritis or multiple sclerosis. And here, very rarely, they're a window into what's going on in this person's blood vessels in their body. And I think it's so unfortunate that this happened, but I'm really glad that you all caught it early, and hopefully he'll have not complete, but a dramatic improvement in his vision with it all. Yeah, I learned so much. I love opto cases because they're usually very, very, very tricky to get to the bottom of. So thank you so much, as always, Katerina, for highlighting a lot of learning here and always keeping us on our toes. Alrighty, Rafa, take us home, please.
First, thank you, Katerina. Like, I was blown away with this case. I'm actually shocked. Like, oh my God, such an incredible case. Thanks for representing that. And thank you for everyone who joined us today. So we had this patient with sudden vision loss, and Ravi started thinking about neurological and non-neurological causes. And the morbidity associated with neurological causes, we always have to assume neurological causes until proven otherwise. And when it comes to neurological causes, we could think about stroke, especially if this is hyperacute and associated with focal deficits, or even tumors leading to increased intracranial pressure, leading to blurry vision, nausea, and vomiting. And non-neurological causes, we thought about embolic causes like AFib, endocarditis, vasculitis, And then we try to divide the vision loss between binocular versus monocular causes. Monocular causes, it's usually disorder anterior to the optic chiasm. We could think about ocular disease, ischemia, ipsilateral carotid artery disease in the case of central retinal artery occlusion, especially because this patient had AFib on the background, so an embolic cause increasing the likelihood of that being embolic in nature. And always we have to remember that even though patients are on anticoagulation, that doesn't bring that risk to zero. And when it comes to binocular cause, we could think about damage to the optic chiasm itself, but also the tracts, radiation, or the visual cortex. And then we saw on this exam that this patient has hypopion, and we thought that hypopion is actually a pus accumulation, i.e. inflammatory infiltrate in the anterior chamber. This can be seen in the endothermitis, which is an inflammation of the occlusal the vitreous humor. We could see that in the case of Klebsiella, Staph aureus, which was the case, Candida, and strep infections. Hypopion, we can see that in keratitis and uveitis. And then when it comes to uveitis, also good to remember that the uvea is this complex of the iris, ciliary body, and a choroid, and uvea inflammation, it's uveitis, and can be divided into anterior and posterior. When it's anterior, it's usually only iritis, and then when it's posterior, choroiditis and or retinitis. This can be seen in conditions associated with HLA-B27 associated conditions that I always remember with the mnemonic pair, like psoriatic arthritis, ankylosing spondylitis, IBD, reactive arthritis, but also rheumatoid arthritis, sarcoidosis, and JIA. So thank you, everyone. I hope everyone enjoyed this case, and I hope to see everyone tomorrow on Global VMR.
I love it. A superb summary. I always worry about I in teaching, and I think you absolutely nailed it, my friend. Bye. See you soon.